I'm going to speak into the mic so that those on Zoom can hear me. Welcome everybody to this afternoon's presentation. It's my honor to introduce Dr. Yanina Pepino. She's a member of my NIH Career Development Grant Mentoring Committee. So today she and Dr. Shah were here to help me fine-tune a few things. So back to the task at hand. Dr. Yanina Pepino is currently an associate professor of ingestive behavior at the Department of Food Science and Human Nutrition, and also within the Division of Nutritional Sciences at University of Illinois at Urbana-Champaign. Her PhD training was in chemistry sciences from University of Cordoba in Argentina. Dr. Pepino was a postdoctoral research fellow in chemical sciences at the world-renowned sensory lab, Monell Chemical Sciences Center in Philadelphia. She also trained as a NIDA T32 postdoctoral fellow at WashU in St. Louis. Dr. Pepino has won many distinguished awards throughout her career, and notable among them is being a nerd. She's definitely famous here in our department. In 2018, she was awarded the Boyd L. Odell Lectureship Award. She has served on several NIH review committees as an ad hoc reviewer and also as a temporary member. Dr. Pepino is funded through the American Diabetes Association and the National Institute of Health. She has over 60 peer-reviewed publications to her credit and has been invited to speak at numerous conferences and platforms. She has held various offices in professional societies and is currently the program chair-elect of the Association for Chemoreception Sciences, ACHEMS. Dr. Pepino's research focuses on the study of the analysis of taste perception with nutrient metabolism and the impact of dietary choices on health and diseases in people. She studies individual differences in human taste perception and preferences with emphasis on sensory control of food and alcohol consumption. She has been doing some cool research, examples of which include studying taste perception, eating behavior, and alcohol drinking behavior in a bariatric surgery population. She also studies fat taste perception and the effect of non-alcoholic sweetness on taste preference and glucose homeostasis. Today, she's going to be sharing some of the data from clinical research on ingestive behavior following bariatric surgery, that's bypassing sweets for alcohol. So let's have welcome you.
Thank you, Catherine. Can you hear me? Is the microphone working? Thank you so much. That was really nice introduction, and really, I am honored, and it was a pleasure to be here today. I always feel like going back home, and this is like a sister of our university, and getting with really friendly and really interesting conversations with colleagues, and really it's a highlight for me to come here to your committee. So thank you for having me. So as Catherine mentioned, today I will share a little bit of a different part of the story of the research going on in the lab. It's not moving. With the mouse. Okay. And so today we'll talk about the research we're doing with bariatric surgery. I am fascinated by what happened with this surgery. I see it as a model to really understand appetite, the physiology of appetite, eating behaviors, and now learning about alcohol. And so you may be familiar with how bariatric surgery has become really the most effective treatment that we know of today for severe obesity and even some other diseases such as diabetes. And there is different flavors of this surgery. They come in different models, and some of them are outdated, no longer almost use it today. When I started research, the most common were the Roux-en-Y gastric bypass that you can see here on the left, and laparoscopic gastric banding. And I put it here just as a almost historical interest, and it was a really nice control group that we could use in the past. To this day, it's very difficult to find lap bands. Less than 3% of the population undergo this surgery. And this surgery that when I started doing my studies was not even in the picture. Sleeve gastrectomy now become the most used, and more than 80% of the procedures are in the country and in the world are sleeve gastrectomy. So what they all have in common is that they reduce the stomach capacity. As you can see, it becomes like a little pouch. But unlike the laparoscopic gastric banding, these other two surgeries also change dramatically the GI. And as you can see, and these two surgeries, all these surgeries also are really phenomenal, as I mentioned, that they make an impact, really a dent into obesity, not only in losing weight, but also people are able to keep it for a long term. At least most people. Unfortunately, not everybody, but most people can keep it like this. They follow them for many, many years, and they're still able to keep that weight loss. People lose around 30% of their body weight, or otherwise 60 to 70% of their excess body weight, and they keep it for the long term. Now, as I mentioned, the two most common surgeries now these days are the Roux-en-Y gastric bypass and the sleeve gastrectomy. And unlike the laparoscopic gastric banding, you can see that there are changes in the GI. As you can see in the sleeve gastrectomy, the stomach becomes like a long sleeve, like a banana. More than 2/3 of the stomachs are removed. Where in the gastric bypass, in addition to creating this small pouch, then you also have, as the name indicates, nutrients and alcohol, as I'll be talking later, bypass most of the stomach and the duodenum. So an interesting observation here for me that was coming from the world of understanding how people eat what they do and how we differ in our taste perception is that these patients will go and report spontaneously to their doctors, to the nutritionist, that they change what they like to. And they said, my taste perception changed. They said, doctor, did you change my stomach or my brain? Because now I don't like the same things. And interestingly, what they didn't like the same, what they changed in their taste, if you can see in the graph here on the right, I'm sorry, what I have here is one surgery I didn't put in the first slide because it's no longer in use. It's a vertical banding gastrectomy in which they were using staples. It was more of a restrictive type, kind of thinking of almost like a lap band, but it have a lot of issues and it's no longer in use. But you can almost think if it was like a lap band versus the gastric bypass or Roux-en-Y. And you can see that after these people receive these different surgeries, in particularly after the gastric bypass, they will report eating much less desserts, cakes and cookies, candies, and more fruits and vegetables. And those for the audience who are in dietetics, you know that you will love your patients to come back and tell you these things. Now, these people will do this spontaneously after the surgery. And as I said, most of them will do it. They will report, yes, it changed my taste. And so this, of course, piqued my interest and many others people also. We start understanding what's going on with these people. One of the things that say, well, you know, these are pretty basic surgeries. They had to commit to a lot. They go, so maybe they also become more adherent. They want to really, for the first time, follow what the doctor is telling them to do. But very clearly, that was not the case because you can really replicate many of these effects of changing in what they like to eat and their taste perception in animal models, who they don't have to tell anything to the surgeon or to their doctors. They just eat what they want to eat. And they don't eat as much sugar. They don't eat as much fat. And so something is going on. So when we think about taste, in coming from my 101 of taste perception, there is in this world of taste perception, what you can measure in the lab, there are different dimensions. One of them is quality. So very easy, like is sweet, salty, bitter, sour, umami, does it change the quality of your taste? Some people, that's very robust and very difficult to change really quality, although there are some few things that can change it. But most likely there are changes in intensity or hedonics. Intensity is related to changes that are related with how strong you perceive the intensity of the taste, the perception of that quality, but also could be referring to how sensitive you are. So what is the smaller concentration that you can detect and say, this is different than water, for example. So people measure detection thresholds, recognition thresholds, or really what happened at much higher levels of intensity. And so one of the questions you can ask is obesity, is this metabolic surgery associated with changes in detectability of sugars and the sweet taste intensity? Or you could also be looking at changes in hedonics. And this is more related with associated with changes in the pleasantness of sweet taste. So how much you like it or dislike it, how much pleasure you derive for that experience. And so when people talk about it changed my taste, you really don't know what they're saying they change. Moreover, we use taste as a synonym of flavor. So we don't even know if when they say change taste, it's changing retronasal, really the flavor of the coffee or the taste of bitter, sweet and stuff. So a lot of things to ask in the lab. And so in psychophysics, we talk about the sensory discriminatory component and we think of more of the peripheria, something going on with intensity. Whereas we talk about more the affective component or more related with the central nervous system related with the hedonic value. And so we did a lot of different studies. This is the study design. We recruit 20 to 70-year-olds people undergoing bariatric surgery. Most of them were women. And you can see that we study them with a big battery of taste, and I will not spend time in all my psychophysics, but if any of you is interested, I'd be very happy offline to give you all the details. But we did a detection threshold, recognition threshold, supra threshold, preferences, choices, a lot of different things to study their sensitivity and changes in how much they like it. We saw them again. They went through surgery that of their own choice or discussion with it. It's not randomized, of course. We studied them when they lost 20% of their body weight after these surgeries, and we repeat exactly the same battery of tests that we did before surgery. And what we found, to be in summary, so let me walk you through this. This is a logarithmic scale because it's very small concentrations of different basic tastes. I wanted to measure glucose separate from sucrose because at the time when we designed the study, we started thinking about receptors that were unique for glucose, not just the unique sweet taste receptor for all the sweeteners, but glucose may be different than others. I wanted to study glucose, sucrose. We studied salty taste with sodium chloride. Monosodium glutamate is a prototypical study taste for umami, that, savory taste. And what we found before and after surgery, and this is collapsing all the surgeries, there were not really differences between any type of surgery because, as you can see, there was also no difference between before and after surgery. And the values that we found, I translated here in millimolar, so it's easy to look in the literature, are right on target what you will see with people with normal weight, with people with no problem. So it doesn't matter if they were with severe obesity or after they lost weight, energy negative, their sensitivity to say that something was different than water was the same before and after. And we know that we are much more sensitive to detect sodium, for example, than sweetness. And we know that sucrose tastes more sweet than glucose. And so the thresholds follow very much in the literature, but we were very convinced that it's not the fact that if they say they change the taste, is that they become more sensitive to detect sweetness after the surgery. I also look at what happened supra-threshold. We look at what happened with concentration of sugar. To put in, let's say detection threshold of sucrose is around 10 millimolar. Well, a soda has like 300 millimolar, 350 millimolar. So we look at also all these higher concentrations. There were never differences between before and after surgery. Where we did find a very important difference is in how much pleasure they derive from tasting something sweet. And so in this task, as you see 1 to 10, they have like 10 different cups and they're tasting one at a time. They don't swallow, so no dumping syndrome. They just taste it, they spit it out. And they need to tell us in the world of pleasurable, of the pleasure and displeasure, how they felt that experience. And we don't tell them there will be 10 cups of sweetness, the same thing, but when they come after, they already know because they did the same test before. But in any case, we ask them to evaluate each of the time as if it was unique. And at this moment, when you taste this, how do you feel? What pleasure you feel? And this is, imagine if you were sipping from a beverage or if you were eating from a pudding, or like the very first spoon tastes different on how it tastes the last one, on how much you like it, right? And what you can see is that we find a main effect overall, right? Of course, there was an effect of time. There is an habituation, that goes down. But the main effect way, they change their diet, they're eating less sweet. But it was interesting to see that when we look at what happened with the women the people who get the lap band, they lost the same amount of weight, 20% of their body weight. They were almost fed the same diet they were asked, they have to follow almost perfect the diet of a Rouen Y to lose that weight. And you can see that before and after, there were really no differences. And they were all the time in the world of pleasantness. So overall, they like it. Whereas those with the surgery, they like it maybe at the very beginning, but very rapidly they went into, it's not pleasurable. And so in conclusion, for that part, I will say that when we look at the different dimensions of taste perception, there is not really a difference, at least in our hands, in our lab, on sensory intense, but it is definitely a difference in how the rewarding value of that sweet taste. And this is really very nice pleasure derived from sweetness. There is studies that show a decreased brain reactivity to pictures of calorically dense food. There is studies that show the motivation to work, like, do some task in order to obtain, let's say, M&Ms. They have reduced motivation to work for something sweet after surgery. So all these things kind of tell us that, yes, it's changing taste. And most likely when they say change taste, at least one thing that we know for sure is changing is how the hedonic value of sweetness. Now, by the same token, I say bypassing sweets for alcohol. One dark side of these metabolic surgeries is that very soon after surgery, they start finding that there was a twofold increase in the likelihood to develop an alcohol use disorder. Particularly, it all started with they look at after gastric bypass compared with those who underwent banding procedures. So it's not that they change their style of life, they change their friends, they change their habits. It was something more related to what happened with the surgery. And we know that because animal models also show that in rats, when they gain weight, then they do these surgeries, that they will drink more alcohol, they will self-administer more alcohol. So we know that there is some biology behind and this seems to happen something after 2 years of surgery. So the increase, and in fact, in the first year, if anything, you see a decrease up. Oncology, right? Is that the faster potential. And that explains why, for example, people are not sharp and sudden changes in different things. So drugs that brain in really had the chance to be addicted. And this has been shown with many different, and this is a cartoon show the concentration in the brain, and you can see that it also nicely correlates with the high, feeling high of a drug. And you can see that the IV, smoking or snorting are much faster and much effective at inducing addiction than, for example, something going via oral or skin. And you can imagine that these surgeries that dramatically change the GI piping, it will have an effect on these pharmacokinetics. And so way 400 it means in okay, it's not that they go 400. The 400 is the translation, but it means uncountable. And this is one of the many Totochtin, the 400 uncountable I think it's a very good representation of it's important. But something we know is that these individual differences in how you feel when you drink alcohol are associated with the chances of developing an alcohol problem. And the more you feel the stimulant effects and the less you feel the sedative effects, the more likely that you're going to continue drinking, maybe binge drinking, and that will get into a cascade of events that will be more likely to give you a problem with alcohol, an alcohol use disorder. And so understanding how you feel when you drink is also part of the picture of understanding increased risk on developing an alcohol use disorder. So the study I will share with you today aimed to determine the effect of the gastric bypass and sleep on both the pharmacokinetics of alcohol when they were ingesting alcohol, but also on the responses to alcohol when they were given alcohol orally, how they feel the subjective effect of alcohol. And also because it changed the pharmacokinetic very dramatically, as I will show you in 1 minute. Another paradigm we used was to give them alcohol IV, because that way, if we can clamp alcohol and make everybody follow the same pattern of response, the brain will be exposed to the same blood alcohol levels. And we can measure then differences in people controlling precisely how much alcohol they have in their brain. We could also look at acute tolerance. So I will show you in a little bit how we look in the clamp to how people may develop acute tolerance. And one part I will not show today, I haven't processed the data, that we also do self-administration, just like rats we place on a table, and we study how much they're willing to work for getting a little bit of a shot of alcohol delivered. And so, and we make it a very typical exponential task. So at the beginning, you do the task 2 times, you get a little bit of a sip of alcohol, but then you have to do it 4 times and 8 times, 16 times. Very quickly, you have to do a lot of work for that. And it's a good measure to look at the break point or how much you're willing to motivation to get that alcohol. But that I don't have data now to show you. So what we did find is that lip gastrectomy and gastric bypass, they were both equally kind of dramatically changing the pharmacokinetic of alcohol. And in a way to remember is like they can convert 2 drinks to 4. It's a very cheap way to get drunk. Because as you can see here, axis you have the blood alcohol concentrations. And by the way, these are not measured with the breathalyzer. These are measured through arterialized vein samples. And then people drink a dose of alcohol based on their fat-free mass. So on average, if you look, they were on average drinking 1.7 standard drinks. Some people drink 2 standard drinks. Some people 1.5. Some people a little more than 1. Is calculated based on their fat-free mass. I will show you later why that's the case, but alcohol doesn't go into the fat compartment, okay? So if you give them by kilogram, you're overdosing people with obesity. Now, what you can see is that before surgery, even when they were drinking a little bit less after surgery because they were lighter, they reached double levels of blood alcohol levels. Not only they reached double, they also reach it much faster. So after surgery, they reach this peak between 5 to 10 minutes after they finish drinking, they are at peak blood alcohol levels. So something that a person will take them 4 drinks to drink, they will get it with a little bit less than 2. And I used to say, oh, this is like having gastric bypass, this is like having alcohol IV. But then when I did alcohol clamps, I learned, no, you know what? It's faster than an alcohol IV because the portal vein can take so much more alcohol much rapidly than you can infuse in the veins, right? Before burning somebody with alcohol. So it is really remarkable change. And people got really, really drunk with these huge blood alcohol levels. Now, I said people got really, really drunk, and that's what you think on average. But I'm also very interested in looking at, as I mentioned to you, individual differences. Not everybody feels the same. So here is a study in which, here what we did in this paper was dividing people based on their sensitivity to the effects of alcohol. And so based on a questionnaire that I got from our colleague here, Bruce Bartolo, they looked at alcohol sensitivity questionnaire. We asked people, how many drinks does it take you? And so this is not something in the lab. We said, on general, how many drinks do you ever feel more talkative after drinking alcohol? Yes or no? And if you say yes, how many drinks does it take you until you start feeling more talkative? How many drinks does it take you to feel more sleepy? How many drinks does it take you to feel, and you go on, and then you cannot get a number. And so we put all the people in a range, and we took the lowest tertial and the highest tertial, and we said, these were the low sensitive, they can take 3 drinks or more to feel this effect. And these people with less than 1 drink, they already are feeling all the effects. And then what we look is at how they felt in the lab when they were drinking the alcohol we were giving to them. They all get the same dose of alcohol. And what you see here in the areas that are in color are the blood alcohol levels that you can read there on the y-axis here on the right. And so you can see this is not copy-paste. They're actually a tiny bit different, but not much. They're not significantly different. And they all are reaching these high points of around 100 milligrams per deciliter within 5 to 10 minutes after they finish the drink. Now, what is remarkable is how they're feeling. What I illustrate here are the sedative effects of alcohol. And these people came in the study on 2 times. One time they have a beverage that we put smell of alcohol, another time they have the real alcohol. And so to reduce some of the expectations, right? Because sometimes it works on the first day, you got the placebo. If you got the alcohol the first day, second day, you said, there's no alcohol here. But if you got the first day, the placebo, you're like, I think that I smell some alcohol, and being there, I'm feeling really very relaxed. So you need to work for expectations. But you can see that didn't cause any sedation drinking that smell. But you can see that on the day that they drink the alcohol, this group who were telling us they were highly sensitive, actually they did feel higher scores for sedation. Now this group, very rarely, if at all, they feel at one point some of the sedative effect of alcohol. And this to us was really surprising, considering that they're having 100 milligrams per deciliter of alcohol, they were just not feeling it. So we think that this third of the people are the ones who are going to be at risk, that now the body are processing alcohol much differently, but they didn't update the system for some reason. They are not getting this sedative effect. So there's no break in the system to tell them when to stop. Do you have any questions so far? I talk so fast, but yes, I get excited with the data. So, but at any point, if you have, please raise your hand and I'll be happy to stop and listen to you. So, yes. Great question. Thank you for reminding me this. So we recruit, all of them are light social drinkers. And so we wanted to start originally with trying to understand not the most simple naive population, if you will, to then understand the mechanism of what is changed and what is going on before bringing people who already have a problem, and then alcohol will also cause and change some metabolism, generate more issues. So all these people are social drinkers. They have to drink alcohol at least once a month. They should never be binge drinkers. They never drink more than 4 drinks over 2 hours. And they are usually drinking 2 or 1 to 3 drinks in a week when they drink most. Yes, Amadeo.
I'm not sure if it's going to functional morphological change or like more lean mass in the high end.
I will talk about fat-free mass in a little bit, but thank you. Keep your thought. So this is how we look kind of like the data for the alcohol clamps. And so remember, I told you we need to look at alcohol clamps. So alcohol clamps have 2 fascinating things that we can use for this set of data. One of them is that once you reach the steady state in the last 30 minutes, the amount of alcohol we are infusing is very much the same as the amount of alcohol that the body is eliminating systemically. And so that is a very nice measure of alcohol elimination rate without any confounding of alcohol absorption. Because when you give alcohol in an oral challenge, at all times of your curve, you have, okay, mostly at the beginning it's alcohol absorption, then mostly is the process of elimination. But even during elimination, alcohol will be still absorbed from some little remaining in the stomach and getting, depending gastric emptying, going in the intestine, is absorbed much faster from the intestine than the stomach, and so on. So this is a very nice measure for alcohol. And then you see them how they feel at the beginning when they reach the high level, and then you study them at later points. And so if you, there are kind of at least 2 different responses, let's say. You could have people who become more sensitive to the effect of alcohol. So you feel sedative, and then as the more alcohol is getting and your steady state, you're feeling more and more heavy-headed, and you get more of the sedative effects. Or maybe you can feel that at the beginning you feel sedative effect, but then you start like rapidly feeling like, oh, I could drive now, right? So that is what we call acute tolerance. So you still, your brain sees the same alcohol levels, but you respond very differently and you're more adapted. And we know from the literature that the people who can handle their alcohol, if you are able to develop acute tolerance well, watch out, because you're at higher risk to develop an alcohol problem. Because there's nothing to stop you drinking. You're like, you don't feel it. You're just feeling good. And you feel the other part, the stimulant effect. So our hypothesis is that during the sleep, because the sleep is causing this dramatic change in the pharmacokinetic that is bombarding your brain with this huge amount of alcohol in so quickly, we think that the brain will try to develop acute tolerance. And so that the surgery will help them develop acute tolerance faster. And so I always say, what they're doing with the surgery at the beginning is like a cheap date, and at the end it's a cheap binge drinking, because they have 2 drinks and they're drinking like if you would take you 4 or 5, and they don't have to go through the hangover because they don't have all that alcohol that you need to reach that 100 milligrams. Then you need to deal with it for several hours. They have like this on and off response. So it is kind of like very interesting change. And so this is with a grain of salt, because this is very preliminary. COVID got in the middle. My alcohol was recalled. My sample size is suffering from that. We have some more than here. The trend is still there. So what you can see here, and I don't know, you may say, well, there in the baseline, you already have almost different, but okay, in the post-hoc ANOVA, it didn't come out significant, but I see that it's almost like it's different people. These are pre-surgery, these are post-surgery. And it kind of looked that in pre-surgery, people start feeling the sedative effects, and as the clamp progress, they start feeling a tiny bit higher at the end, right? Even more sluggish and sedation. Whereas the people that underwent through this post-surgery and now they're experiencing alcohol in a different way, Now they feel the effects of alcohol much faster, the sedative effects, but then they start going towards baseline much rapidly. So they will develop acute tolerance easily compared to pre-surgery. And this is preliminary, but it goes into the supporting of the hypothesis that I think is logical. Yes. Great question. These people are 1 to 5 years after surgery. Yes. Okay. What do I want to say? So conclusion of this part of what the surgery does to the alcohol and how they feel, we think that both gastric bypass and sleep, they cause a fast and a high exposure of brain to alcohol. They can turn 2 drinks into 4, which we know, and I didn't tell you that I had there that red limit. It says we know 80 milligrams per deciliter is the legal driving under the influence limit. But it also coincidentally is a threshold that we know that is associated with alcohol problems. So people that engage into drinking patterns that go above that level, they are at higher risk to develop an alcohol use disorder. Now, this surgery is making people reach those levels with the social amount of drinking. So when people go and talk with the patient, I think that we need more doctors being aware that if they have gastric bypass or sleep, if they say that they're having 1 or 2 drinks every weekend, maybe you want to ask more questions and see how fast they drink that drink, or they drink it with something else, because maybe it's like if somebody didn't have the surgery, tell you, well, every weekend I have 4 or 5 drinks. And I think that somebody will have a different conversation when they are going to be. So being aware what is binge drinking may be different thresholds. Or sometimes I even envision products and thinking, oh, for bariatric population, they should do half the shot, you know, because they're processing differently. So another conclusion is that the rapid onset of alcohol effects and the rapid development of alcohol tolerance, if it's true that data that I showed you preliminary remains, that can also contribute to the observed increase in the risk of developing an alcohol use disorder after this gastric bypass and sleep. So we really hope that, you know, we need to increase the warning of alcohol beware, both in people who undergo this surgery, in friends and family of them, in doctors, in medical. We need to understand and say more. It's not to say do not have the surgery, but it's to really understand that there is something going on, but the biology is changing. Yes.
Go back to that slide. So they're on the right, after surgery, they're feeling less of the sedative effects. When you have their implant.
That's right.
So it's like brain increasing processing, or
is it pharma?
Get from that to a peak.
It's a pharmacodynamics effect, right? So I can imagine maybe down regulation of some receptors or changing in the, you know. We're trying to get into there now. We're trying to do some studies to understand alcohol metabolism in the brain. But because you're right, it is in the blood that is the same. Yes, absolutely flat. And there is a lot of literature, not just in bariatric population, in people that we know that they do the clamps and we respond differently. And it could be even your setup, right? Different dopamine, you know, even in the career for an alcohol use disorder, there is development of tolerance. That's one of the criteria for addiction, right? You need to drink more to feel the same effects. So there is a whole cascade. There are many neurotransmitters that are in that cascade that you feel. For example, that's one of the reasons why you have a hangover or the seizures, right? Because all the stimulatory part go up and the sedative effect goes down. So then when you remove alcohol, then you have all the stimulation up because you're trying to adapt. So when you drink alcohol, you feel normal. So all those neuroadaptations are part of this acute tolerance to alcohol. Make sense? Yeah. Thanks. Okay, so, but as I told you at the very beginning, and I have no idea what, well, I have to wrap up here. So bariatric surgery is a powerful experimental model to me to study also the physiology of appetite and reward. And I will argue also to look at the metabolism of alcohol. And one thing that I was puzzled from the, I don't know, since my graduate school, when I was looking at metabolism of alcohol in rodents, it was about the first pass metabolism of alcohol. You know, the wisdom, never drink on an empty stomach, right? Because when you drink with food, the alcohol stay longer in the stomach, you can more rapidly, it happens, many things happen. So less alcohol reaches the bloodstream. And it is either because the liver or the stomach was metabolizing that first fraction on the path of alcohol, and so less alcohol goes in the bloodstream. And so it's been forever the discussion whether the first pass metabolism happens in the stomach or the liver. There is a group of people thinking it's the liver because 98% of alcohol is metabolized in the liver anyway. So why will the first pass not be in the liver? And there's other people thinking, no, it happens in the stomach. But many people that think it's in the liver, they say, look, the stomach is important, of course, because if you delay the gastric emptying, if it is processed in the liver, because it follows a saturable process, when you give the stomach, the liver, alcohol in a big bolus, alcohol will go in and then it gets saturated and most of it goes in the bloodstream. Now, if you give them slowly in little drops, liver will take alcohol, metabolize it, and very little will escape. And so the slower the stomach delivers the alcohol to the liver, the more effectively the liver will handle it and less will be. So I hope you get the story that there is a first pass metabolism. We all knew about that a big fraction of alcohol, in fact, if you consume with food in an empty stomach is not as much, but a portion of alcohol goes and gets metabolized before ever reaching the bloodstream. You never see the brain. In fact, the group who were really robust and thinking and challenging that it was in the stomach used the gastrectomy to show that it happens in the stomach. They say, look, you remove the stomach, you remove the first pass metabolism of alcohol, because they show if you look at here, people without any surgery, and you give the same dose of alcohol orally versus intravenously, all this different. Here is the first pass metabolism of alcohol. Now, I give this to a patient with gastrectomy, and they have identical curves. But the people who think it's in the liver, they say, not so quickly. Because it's a saturable system. So if you give at what velocity you deliver alcohol to the liver will explain how much you can handle. So if the stomach is not there, alcohol will go like the tube to the liver will be overwhelmed, a little bit will be saturated, and then the rest will go in the bloodstream. So you didn't show me nothing other than the stomach is important in delivering the dose of alcohol to the liver. And in my mind, I studied pharmacy, it was the liver. I always thought, yeah, some people say the stomach, because there is other data I'm not showing here that it kind of make you think, oh, the stomach has something to do too. Until this day, last year, when we were studying one of our participants with a sleep gastrectomy. And just by serendipity, really was luck that you have this is the data of the person before surgery in this dark purple. And this is the same person when she came after, 6 months after she has the sleep. And it was interesting to me because when we do the gas chromatography, I always have the data from before and I check. And I was like, it was interesting that before surgery, first of all, she was an odd value. Like just by luck, I think when she drank alcohol, she was in the phase of gastric emptying. And so her peak was very quickly. And it peaked 10 minutes after she finished with the drink. So 20 minutes after she started drinking, she was at peak levels. This is very rapid and not unusual, but not the most frequent response. Now we have double luck here because not only she was very quickly in the pre, but she was one of the slowest in the post in the sleep. So that in her data after surgery, she peaked at 15 minutes after drinking, finishing the drink. Typically, people drink between 5 to 9 minutes. So here, this woman was atypical, yet I was like, hold on. If it is in the liver, then the liver had more time even after surgery than before surgery to process, yet the blood alcohol level was still double. And then I said, the pylorus. And so I said, yes, it's not too long that they will take, but maybe what we can do is to get a group of people, of women without surgery, and then we match them on their BMI, on their age, on how much alcohol they drink, on anything that we can. And even we match them on the time to peak. So we run more people than we need to get 7 in each group. And so if we match the 2 times to peak. And another thing that we did, I'll show you the rationale. You see, okay, pylorus, remember, we can hold now for some time. The gastric bypass, you cannot hold it. But this surgery allows us to ask this question. And so our rationale was that if we compare operated versus non-operated, they were all women who achieved the same time to peak after drinking. Another important part, if we check that their alcohol elimination rate was the same, because we have alcohol clamps. Remember, I told you can very nicely measure how much is being cleared by the systemically, because I said maybe after surgery, the liver got sluggish, took more time, and that accumulated alcohol, so my peak is higher. So we need to make sure that it's not a difference in the alcohol elimination rate in the liver. So if we give them all that and their only change is that the peak is higher when they have the same time to peak, they drink the same dose, they have all these other things, they have the same alcohol elimination rate, then I can kind of say with more certainty, it looks like in women, first pass metabolism of alcohol is in the stomach. And so that's what we did. And so we got these people non-operated, operated, matched them in BMI, age, alcohol consumption pattern, they were all light drinkers and so on. We did the clamp, we did the drinking, we measure blood alcohol levels based on gas chromatography, which is the standard for alcohol. And okay, this is a long story, so let me cut because this is everybody. Let me go to our theory that we want to see. These are matching the time to peak, and you can see that the time to peak is different, but you can see that sleeve gastrectomy still have a much higher peak than those who were no surgery. And we can see if we look at the whole area under the curve, which is give you an idea of the bioavailability of alcohol, it was increased by 34% in those who underwent the sleeve gastrectomy. And we know that was not because of the alcohol elimination rate. Sorry, I want to go back. I don't know how to do with the mouse. When we look at the clamp, there were no differences in the alcohol elimination rate. So we know it was not the liver. We know that this difference of an increase, and even if we don't look at only just the one with matched time peak, even if we look at everybody, we see that there is an increase of around 34% of the alcohol variability when they had the sleeve gastrectomy. And so we see when stop the first in the liver. And so 1 minute, because remember I say, so this when they lose weight, they lose mostly fat compartment, but they also lost some fat-free mass. And what we were giving the dose of alcohol we drink based on their fat-free mass, because we thought alcohol doesn't go to their fat components. So bigger. Okay, so we see that alcohol elimination rate is higher in people with obesity than those of normal weight. So on average 7 grams, the other ones are around 9 grams. But the interesting thing is that when we look at those who, if we look at fat-free mass and we put it in the model, you can see how much nicer the regression comes. If you look at fat-free mass and age, they explain 70% of the variance in the alcohol elimination rate of these people. And I want to say that it's not that alcohol is going into the muscles. It's just that fat-free mass correlates super nicely. It's a good predictor of liver size, at least with the liver that is healthy to metabolize things. And so we think that it was very lucky, and that is a good method to show that when you treat alcohol challenges in people, it will be good to give them the alcohol dose based on fat-free mass. So I will just move into the acknowledgements because there's a lot of people working with me, and I want to be thankful. My current postdoc here, Neda, is working on this project, but before I had as a postdoc, Belen, Raul had been working there too, the phlebotomy, the many undergraduate. I think that even Amadeo did some blood tests for us in the very beginning. So thank you, Amadeo. They also people, like surgeons at Carl. I also, as I mentioned, Bruce Bartholo from here helped us with the alcohol sensitivity questionnaire. My collaborators in Indiana and in NIH and funding. And sorry that I talked so long, and I should have cut 3 slides.
About how is there any interest in GLP-1 agonist?
Very interesting. Because thank you for the question. Do you think the Zoom are gone? Should I repeat the question? So given that GLP-1 is so important for gastric emptying, is there any interest in understanding how GLP-1 and these medicines that talk with GLP-1 may affect alcohol metabolism? And GLP-1 is interesting because it's not only involved in the alcohol metabolism, perhaps but indirectly, at least by modifying gastric emptying, we would expect that if it causes more of a delay, the gastric emptying, then you'll be able to metabolize more alcohol before it goes and hits the liver. So we'll be protect the liver of some of the toxic effects of alcohol. But interestingly, GLP-1 also have central effects on the how do you feel the effect of alcohol. And there is now a lot of data showing that when you have a higher GLP-1, you kind of lost a little bit of the wanting or liking for alcohol. And so people who are in these drugs actually are reporting that they drink less alcohol. And so even interestingly, people with the bariatric surgery at the very beginning, if they were not having an alcohol problem, but let's say they were more on the heavier side of drinking, they said that they found much easier not to drink. And during the surgery, they had these huge responses on GLP-1. So in animal models, when they give them GLP-1, they also can do rats who are heavy drinkers to consume less alcohol. So we could, despite them even having less alcohol, you will think they would drink more, but they drink actually less because they don't feel the rewarding effects as much. There are also variations, NEPs in the GLP-1 receptor that are associated with changes in how they feel when they drink alcohol or with the prevalence of having an alcohol use disorder. So great question, thank you. Wow, I don't know.
So you mentioned earlier, like, your eating status is gonna determine your absorption of alcohol. And with bariatric surgery, there's obviously heavy changes in eating status. Control, when you did these experiments when you had to drink alcohol before and after surgery, how did you control their diet before and then? Obviously after bariatric surgery, they can't eat much once it is.
Great question. Let me repeat it. So being fed or fasted will affect your first pass metabolism of alcohol and metabolism of alcohol in general. So did we control for that in our bariatric studies? And so all our studies were in the fasted state. So people were drinking in an empty stomach, 10 in the morning. Not very biological. So, but we are working now in understanding fed versus fasted because it's a fascinating question. Now it's a question that clinically we need. Because it's surgeons cannot tell them, to people, they will say, always drink with food. But is that a really good recommendation for surgery? I really don't know. You would think it is, but we need to know. In fact, they are tell that they should separate the drinks from the solids, from the food. So the opposite of what they would happen with alcohol. But we need to see. We need more research. Thank you.
Yes, my technical is that growth point look at vitamin status in the bariatric patients because we know that alcoholics particularly they'll become B vitamin deficient. That's also a hallmark of bariatric surgery. So I'm wondering if that may that was something that.
Good question. And this one is related with the malabsorption of nutrients and vitamins and how they could be vitamin deficiencies. And we know that when they are thiamine deficient, that they can get even worse with an alcohol problem. So if we control for that in our population. So we recruit as healthy as you can. And we didn't pre-treat anything. So I don't know. We only check for the basic metabolic panel and they make sure they have no anemia, but we never check for the vitamins. But I want to remind you that we only recruit people who are light social drinkers. So they typically drink once a week, one drink or two. So, and they are most of them are taking their vitamins because we ask them, at least they report taking them, the multivitamins. It is very common on what they take. Good question.
How about non-consumers of alcohol? Is there any evidence that post-surgery tend to like alcohol?
So what happened with those who never consumed before and now after surgery they start consuming? Do we find any? Well, to be in our study, they need to at least consume one drink. We cannot recruit people who are but it can be that somebody, and we've seen people who did not consume alcohol before surgery, but they start drinking alcohol after surgery. So before coming in the study, they had to drink at least once a month. But there are people reporting, and that's why it kind of was very interesting to see. Typically, you see women in their 50s developing an alcohol problem. That's not what you see. Typically, people who develop an alcohol problem are college, younger kids, and then they go down. And it's not something you will see a spike on women in their mid-50s having an alcohol use disorder whenever they have problem before. But I received many emails of people telling me, I never saw it coming. Thank you for doing this research. I never told me about this, and I got 2 times arrested by driving under the influence. Sometimes they want to call me, can you testify for me? Because it's like, I only have one drink. And I said, I will not help you because with our data, that maybe in the stomach, at least for 5 years. Amadeo. Liver size. No, no.
Oh, it's sleep mask.
Yeah, lean mass is different, but liver, so liver size is the same, but the women have much less fat-free mass. So the alcohol elimination rate in women, if you correct by the fat-free mass, is actually higher than men. But there is a huge confusion on what happens when you drink, men and women, because there are so many factors. Women have much more fat than fat-free mass. So if they drink the same dose, the total body water is different. So women will have much more alcohol in their level than men by the same dose. Now, if you give them the same based on fat-free mass, women will metabolize it more rapidly. Good question. But yes, so for the same fat-free mass, also women metabolize alcohol faster.
All right, well,
Thank you. I talk too much. Like,
No, I talk very fast too. My presentation.
yeah, I had to start
Wrong house, we are giving the topic.
my phone.
I was